Angiomyolipoma and Neuronal Linkage is a kidney tumor made of fat, blood vessels, and muscles. But what does it have to do with the brain and nerves? Uh, that is the important question. Angiomyolipoma is more than a renal mass. It's linked with tuberous sclerosis, connects the kidney, neuron seizures, and abnormal cell signaling. Angiomyolipoma may reveal the hidden connection between renal growth, genetic mutation, seizures, and neuronal dysfunction. The mTOR signaling is play a vital role in this disease, and that is the important connection between the angiomyolipoma and nervous system. Hi, my name is Dr. Wes, and today we're going to discuss angiomyolipoma and neuronal linkage. Core concept is the blood vessels, smooth muscles, fat cells. They contribute to the renal AML, angiomyolipoma. Uh, Usually composed of normal blood vessels, smooth muscles, and fats. Uh, PSC associated with lesion, renal pain, bleeding, anemia, hypertension, hematuria. Large aneurysm tumor carry risk of spontaneous bleeding and require careful monitoring. Disease description, as I told you before, angio, thick-walled, myo, smooth muscles, and lipoma means fats. Symptoms may occur uh, when tumor enlarges, bleed, or compress surrounding structures. Clinical features including back pain, abdominal pain, hematuria, palpable mass, hypertension, or kidney function impairment in selected cases. Type as association, sporadic, most common, small asymptomatic lesions are commonly observed with the imaging. Uh, TSC, tuberous sclerosis complex, driven by TSC1 and TSC2 mutation and mTOR pathway overactivation. Um, Epithelioid AML is a rare variant, can mimic renal cell carcinoma, needs special pathological evaluation. Mechanism, TSC1, TSC2 alteration, that is the genetic alteration, uh, loss of hamartomas, tuberin control, mTOR pathway overactivation leads to cell growth and angiogenesis, vessel plus mass plus fats, and leads to renal AML formation. Vascular components, aneurysm can form inside the tumor, bleeding risk with the size and vascularity. Muscle fat component mass effect can cause pain and pressure. Fat-rich lesions are easier to identify on imaging. TSC length, tuberous sclerosis connection. Some pathway may produce kidney AML and brain hamartomas. Neurological manifestation in TSC include epilepsy, neurodevelopment symptoms. Mechanism, TSC1, TSC2 mutation and mTOR overactivation leads to kidney AML, brain tubers saga plus TSC, epilepsy, and other neurological symptoms may appear. Neuronal network instability. Systematic linkage included bleeding, anemia, hypertension, uh, kidney dysfunction, hypotension, fatigue, poor concentration, headache, reduced brain perfusion. Pain path for linkage, that is important. Large AML and leads to bleed. Renal capsule stretch, uh, nociceptor activation, spinal cord pain pathway, and brain pain perception. Symptoms include flank or abdominal pain. Severe acute pain may signal rupture and requires urgent evaluation. Normal interpretation, persistent pain can increase stress, sympathetic activation, sleep disturbance, and anxiety in these patients. Clinical presentation, small level AML is often silent. Renal function is usually preserved. Symptomatic flank pain, hematuria, reduced kidney functions if the regions are large, bilateral, or recurrently treated. Emergency bleeding might happen uh, in patients. Drop in blood pressure, tachycardia, dizziness, syncope, anemia, and shock uh, may be there. Diagnosis, often first test less specific than CT or MRI, can miss fats, poor lesions, or underestimate complexity. CT MRI, depending upon the type of AML, evaluation, interlesional aneurysm, vascularity, and relation to kidney structures. This assessment that is very important. Aneurysm size, vascularity, symptoms, PSC association, bilateral multiple lesions, renal functions, and remaining healthy kidney tissue. Treatment, for small asymptomatic low risk AML, monitor size, growth rate, symptoms, renal functions, and blood pressure. Patient educate, seek urgent help for sudden severe flank pain, dizziness, or hematuria. Intervention, inform sparing surgery, uh, selective arterial embolism or embolization. Uh, Ablation may be used to extract small lesions. ESC-associated mTOR inhibitors uh, such as everolimus can shrink PSC-associated ML to reduce growth. Treatment decision flow, renal AML confirmed, assess symptoms like bleeding, um, and if there is a high risk of bleeding or rapid growth, uh, embolization, surgery, or mTOR therapy might be there. If the AML is small, low risk, and it is silent, surveillance and education may be required for the patient. Prognosis, good prognosis, small asymptomatic sporadic AML, no prior bleeding, prompt treatment of high risk lesion while preserving renal tissue. High risk features, large tumor, aneurysm, pain, hematuria, pregnancy, bilateral or multiple tumors in PSC. Uh, Epithelioid AML variant may have more aggressive behavior. That is summary. TSC and TSC2 in association with mTOR causes the overactivation, especially in TSC associated AML. Diagnosis relies mainly on CT, MRI to detect fat, size, growth, vascularity. Treatment ranges from surveillance to selective arterial embolization, nephron sparing surgery, ablation of or mTOR inhibitor may be given. Prognosis is usually good when low risk lesions are identified and high risk lesions are treated before the severe bleeding. Thanks and regards. Please like and subscribe this channel for further discussion on rare diseases.